Hello everyone, now I'll be discussing question on cardiology. So we have a 52-year-old man. He come to emergency department due to shortness of breath and dry cough. He has been feeling weak over the last several days. Some dyspnea or exertion is there. And today morning he woke up with persistent breathing difficulty. And he come to emergency department. There is a mild history of intermittent asthma, for which he uses occasionally albuterol, which is a beta-2 agonist. Well, at the moment, his BNP level are increased on a lab investigation. Now, which clinical sign would be best correlate with this finding in this patient? Well, the answer is third heart sound. Why this the answer? Well, as far as patient clinical presentation is consistent with CHF, although he has a breathing difficulty and he is a known case of asthma, but now this breathing difficulty is due to congestive heart failure. It is a progressive dyspnea over days, fatigue, and the most important is elevated BNP level. This is I think most important criteria among all what is mentioned here, because these are non-specific, they can occur in other conditions also. Now, as far as BNP is concerned, it is a natriuretic peptide. It means it causes loss of sodium and water in the urine. So it more of a natriuresis causes loss of sodium. It releases from the ventricle myocyte in response to. Remember, BNP is related from ventricle, and we have one more molecule ANP which come from atria. So this from atria and BNP from ventricle myocyte. Now why? And they are released in relation to high ventricle filling pressure and wall stress in congestive heart failure. And we are well aware in this congestive heart failure there is left ventricle and diastolic volume is increased, and that lead to increased length in the sarcomere also. Now, as far as BNP is concerned, it is derived from prohormone pro-BNP, which breaks down and produces active BNP and inert N-terminal pro-BNP. So we can say pro-BNP, this molecule, break down into BNP plus anti-pro-BNP. This is an active compound, active component, and this is inert. That means, but it will be equimolar, both will be equimolar. That point you have to take it into consideration. So that's why elevated level of circulating BNP or anti-pro-BNP, remember both, they are equimolar, they are all derived from pro-BNP, correlate with the severity of left ventricle systolic dysfunction. Okay, that means if there is left ventricle failure is there, left ventricle dysfunction is there, and that will cause increased release of BNP. And moreover, high negative predictive value for CHF as a dyspnea, if normal values are there, then perhaps this is not a case of congestive heart failure. Now the third sound is a low frequency diastolic sound. It is heard best over the cardiac apex in the left lateral decubitus position. Well, now I have a question for you. S3 is produced in which phase of cardiac cycle? You can stop the video, write down the answer. Well, it is produced in early diastole. Little bit basic concept. This is the heart and this is the valve, mitral and tricuspid valve. In early diastole, the valve open. Rapidly blood will enter into the ventricles. 70% of the blood from the atria enter into the ventricle. Both atria, respective ventricles, 70% blood come. And this is early diastole. This is also known as rapid filling phase of myocardium. Okay. Normally no sound is produced, but if a sound has to produce, then it is third sound. That means third sound is produced in the early diastole or in the rapid filling phase of myocardium. That's why S3 is also known as filling sound. And near the end of diastole, the atria will contract, and that will produce next 30% of the blood into the ventricle. And that's why atrial contraction is called as atrial kick. And normally during atrial contraction, no sound is produced. But if a sound has to be produced, that will be S4. So that's why S4 is also known as atrial sound. But now I have two questions for you. Stop the video, write down the answer. Well, when S3 is produced, some wave will be there in JVP. And when S4 is getting produced, or I can say in JVP, what wave we will see in early diastole and which wave we see in late diastole. Stop the video, write down the answer of these two questions. Which wave we will see in early diastole and which wave in late diastole. Answer is Y descent and A wave. In other way around, we can say Y descent correspond to third sound and A wave correspond to S4. With this background, we come back about third sound. Okay, so S3 is produced by the passive ventricular filling during the early diastole. Why passive filling? Because S4 is produced due to active atrial contraction. It is just simply ventricle is dilating. And this can be now one more question for you. Write down the answer in your copy, stop the video. S3 can be produced in a normal person also. Who are those normal person? Stop the video. It can be heard in children, pregnancy, athletes. This can be produced. Now, as far as abnormal S3 is concerned, it is heard in congestive heart failure due to left ventricle systolic dysfunction. It has got 99% specificity is there. It correlates with the elevated left atrial or ventricle filling pressure. An elevated BNP level, and BNP level are elevated due to CHF, the point I already mentioned to you. Now let's look into other option. Cyanosis is incorrect. But this can occur in so many lung disease also, and the most common cause of cyanosis is chronic bronchitis. It can be heard in congenital heart disease where we have right to left shunt, like Eisenmenger syndrome or tetralogy of Fallot. But it could be rare. It is very rare in CHF, unless in very advanced stage of CHF. Otherwise, cyanosis is not a feature. And cyanosis will not correlate with BNP level, very obvious. This is specific for congestive heart failure. Extremity edema is a feature of CHF and is due to volume overload. But as compared to S3, is total less specific, and it never correlates with BNP level. S3 correlates with BNP level also. Moreover, edema can be seen in inferior vena cava obstruction, cirrhosis of liver, lower extremity venous insufficiency or nephrotic syndrome, or any condition which lead to hypoproteinemia. In all these conditions, edema feet can be there. Neck bruise is present in patients with carotid artery stenosis that we can diagnose by Doppler study. It has nothing to do with congestive heart failure or BNP or third sound. Periumbilical bruise, this we can hear in renal artery stenosis. And this is usually maybe in young ladies or elderly, they usually manifest with hypertension. But definitely it has got nothing to do with third sound or heart failure. Golden line to remember, elevated BNP level an audible third sound are sign of increased intracardiac filling pressure. They are noted in patients with CHF due to left ventricle systolic dysfunction. Thank you very much.